Right, the first question is for Birmingham. I'll get that straight soon.
Okay, B before A, that's fine. Does WM cause arthritis? Well, it can cause inflammatory joint problems because, as I mentioned before, WM is a very inflammation-rich condition, and it can coexist with other what are called autoimmune diseases, and that includes conditions like rheumatoid arthritis. I wouldn't say it's super common, but they do coexist, and some patients do get inflammatory changes in their joints. But the one that more commonly coexists will be osteoarthritis, which is not a causal relationship, but that's wear and tear. So it's important to know if you have arthritis, whether it's the inflammatory sort, which may need some kind of inflammation suppression, or whether it's good old-fashioned osteoarthritis.
But some of the drugs that we give can cause joint pains as well, so not just the disease, but the treatments.
Good point.
And feel free, both cities, make comments about the questions. So I was always an A student, so I don't have trouble with the idea of B going first. The next question is as you notice, we have a token male on the panel. So the next question is for you, Simone, which is we answered this somewhat here, but is venetoclax currently used to treat WM?
Yeah, we already talked about this. Actually, it is not indicated, but it is active. It is an active drug. And so, for example, in Italy and other countries in Europe, we have to ask the named patient program to ask the company to give this drug because it's not indication. Anyhow, it can be active, and especially, for example, I used this drug for patients relapsing after BTK inhibitor. If I have no other drugs in indication, like, for example, non-covalent BTK inhibitors. So you can access to this drug with a named patient program. I don't know if it's so in Netherlands and UK too.
It's the same, yeah. So the problem at the moment is it's neither FDA nor EMA approved. So there's no regulatory pathway also to this drug. So that means it's also not reimbursed. So also in the Netherlands, it's now possible to ask for this, but you have to ask the company, and it has to be a sort of last resort. So there's no other regular therapy for patients to get it reimbursed.
Yeah. So what we do know now, there was one clinical trial performed in the United States with this drug. So that's why we know it's active, and we know how to use it a bit, and we know the side effects in Waldenström patients. So that's very helpful. And I do know that there are more trials coming up with the drug, but at the moment it's only available in the unmet need situation.
Yeah, I think it's good to add, I was going to say the same, and this trial was very small, only 30 people, and it was 2 years treatment. It was very effective, but after stopping, most patients relapsed actually quite quickly. So it seems to be a drug that we need to either take long term or combine with something else to make the effect stronger. So I also think indeed, as a last resort, we can use it, but we don't know enough yet how to optimally use this in Waldenström.
Let me give just a different twist on that and send it back to the UK. What 3 drugs are in the pipeline that you think are the most promising for WM?
So just to give the UK perspective on venetoclax before I answer that question, Monique gave a really good talk on trials and drug development in trials. And in the UK, once a drug has got license for a particular indication, it then needs to be approved by NICE for funding in the NHS. So just because a drug, even if it gets a license, once it's proven efficacious, it doesn't necessarily automatically mean that we will get access to it in the UK on the NHS. So, for example, at the moment, we wouldn't have access to venetoclax for patients with WM. In terms of more generally drugs that are in the pipeline, there are lots of exciting developments, and although WM is a very rare disease, there are other B-cell malignancy, so cancer is also affecting B lymphocytes where there are new drugs, and then once they've been shown to be efficacious in different diseases, then often we will see them being used in WM as well. So for example, venetoclax, we've got experience with it with other diseases. So the way I like to think of it is there's things that can target the outside of the cells. So a lot of you will have had rituximab, which targets a protein on the surface of the cells. And there are other drugs that we are beginning to investigate in WM that target things on the surface of the cells, so other antibody therapies, and then other things that use immunotherapy to target the outside of the cell. So you might have heard about a class of drugs called bispecifics, where you've got a target that targets your B lymphocytes, but it also targets something else, hence the bispecific too. So it targets your T lymphocytes, and it brings your T lymphocytes to your abnormal B lymphocytes and basically tells them that this is the abnormal cell, here, kill it. And then you'd already heard Harriet mention that there are trials with CAR T therapy, again using your own T lymphocytes and strengthening them to try and fight the WM cells. And then there are other things that are being investigated that affect the inside of the cell. So we've already heard a lot about BTK inhibitors. So that's targeting a particular enzyme that we know is overactive in the WM cells. And there are new drugs that are targeting that same BTK. So we've heard about pirtobrutinib that targets it in a different way to ibrutinib or zanubrutinib. But there are also BTK degraders. But then there are also new drugs targeting different enzymes within the cell. So it is exciting times.
Anyone else here want to add anything? What is very exciting news for all of us that we have many, many drugs to choose from now and a whole lot more coming.
Yeah, and also a combination of those things I think are very promising, like to combine venetoclax with other drugs, or when all these new options come up, because they are usually not chemotherapy, but like smarter drugs with less side effects, they can also be combined, and that way used in the fixed duration method and get long treatment-free intervals. That is, I think, a concept that we're also excited about. Yeah.
Although we still need to, also for Waldenstrom, there can be specific or...
Yes.
Side effects. So the fact that it works in other diseases like CLL. We've also seen examples of a clinical trial where venetoclax was combined with ibrutinib and gave serious cardiac events. So
this is
always important of course, also see the effect and the side effects.
It's a lesson we learn again and again. When you talk to the pharmaceutical companies, when they say Waldenstrom is like another lymphoma, we can throw them into the other trials. It really is a very specific disease with its own side effects, different from other indications. So every time we need to do specific trials for this specific disease. And this is a lot of effort, but it's worth it, I think. Yeah,
it is.
But I totally agree with Simone's approach, where we need to learn more about what's happening, not only with BTK, but also downstream from BTK. There are other kinases that are important and that we can also manipulate in the future. Yeah.
Okay, the next question is really a longevity question. So I'll send this one to the UK first, which is how long life do you have with WM? Can you ever be in remission from cancer?
I'll only go on my own experience in that I met people with WM when I started nursing 20 years ago, and they are still alive now. So everybody is very different, though, and everybody's in a different situation, different age, different treatments. But I don't think there's any sort of elixir for life for any of us, or for long life.
Maybe I can also add, I think it is a disease that is very slow and chronic. And the way I look upon it is when the first clock starts when the diagnosis is made, the second clock starts when you actually need treatment. And even at that point, there's a long innings, as they'd say in cricket. There are many new therapies as well being developed. So I think I expect people to live for, honestly, for decades, actually.
Any comments from Amsterdam, folks?
I think our previous PhD student, Karima Amadar, did a study because we have a national cancer registry in the Netherlands. And indeed, she saw that the outlooks or the prognosis for Waldenström patients is over time, over the last 20 years, has been improving all the time. It's also good to realize that when patients get older, and this is actually, it's a bit strange to say, but it's good news in a way, a lot of Waldenström patients die from other causes, like normal people, right? Everyone dies from something, but in a lot of Waldenström patients, it's not Waldenström, it's just, older age or because the Waldenström is not causing them to die. So I think I agree with Shirley that with the additional options that are becoming available now, that I think the outlook is going to be even better. Yeah.
But still, we need to do better because
we're not there yet.
Still access that.
Access.
Absolutely, and also toxicity from the treatment.
Good, but I think that's good news for all of us. We plan on hanging around for a while. The next question is, can you still get night sweats and itchiness despite WM being stable? Let's go to London again, or to UK again. Can you still get night sweats and itchiness despite being stable?
Yes.
We
so
need some
I
short
think just to
questions.
expand.
I'm not giving you guys a chance to disagree with her. Now,
I was going to say
the next one is that can you measure MYD88 and CXCR4 in the blood? Is it less expensive?
Yeah, for sure, MYD88 can be measured in blood, and especially if you use plasma, that is one part of the blood, so you have to use specific diagnostic tests that are very sensitive. For CXCR4 is also possible, but is a bit more difficult because it's a different mutation. There are some technical issues that hinders the possibility of a highly sensitive determination in blood. So probably MYD88, yes, CXCR4 to be sure that whether a patient is CXCR4 mutated or not, you should investigate the bone marrow.
Any different comments from the UK?
Just to answer the second part of that question, it probably is more expensive to test it in the blood because there's less tumour to pick up the abnormal gene, so you have to use more sensitive tests, has already been said. So, I mean, I guess it depends how you define expensive. Financially more expensive, but maybe less expensive to the patient who has to go through the bone marrow.
Okay, so this is a new question, but we don't have the fancy techniques, so this is a raise your hand question. How many people here want to have another bone marrow biopsy tomorrow? Hey, Bob, Perry, and I want to have bone marrow biopsies tomorrow. Nobody else? Anybody?
There is one here.
Oh, somebody else? Oh, another crazy person. I don't know. I couldn't see anybody in the audience over there.
Not stage either.
Can I add something to that? Because I think it's very exciting that we can measure genetic mutations in the blood. So I think we can think about a lot of use of that. But in the end, you can't make a cancer diagnosis at the moment with it because it's defined by the amount of clonal B cells in your bone marrow. So that it seems to correlate, but MYD88 mutations is also seen in other types of cancer. So you still have to know which type of cancer do we have exactly. And on the other hand, we do have M proteins to help us with blood draws to see how your disease is doing. And the other important thing is that with all the drugs that we're giving, sometimes your healthy bone marrow is becoming damaged. So you have anemia, not because your disease is very active, but because there's damage to your healthy cells done. And that's something that we can only see if we do the bone marrow biopsy. So I I wish for a future without bone marrow biopsies, but I want to dampen a bit enthusiasm. I think we will need them, especially for making the diagnosis for a long time.
Okay, thank you.
Maybe, but I would be curious to know, Bob, why would you want a bone marrow? Does it give you more security, or? Mm-hmm. Oh, really? Yeah. Wow. That's
and to donate to the biobank.
The biobank.
Yeah. Well, that's altruism. Thank you.
Did you guys hear that in the UK?
No.
Okay, well, they basically asked Bob Perry why he would be happy to have another one. He said, because A, it says he's still alive, and B, I think it was that it would help the doctor in training, because we all know some guys do better bone marrow biopsies than others. It's like some dentists are better than others. Anyway, the next question is, once you've started a BTK inhibitor, will you ever go back to active monitoring, or are you then on lifelong treatment, including changes in BTK inhibitors when they stop working? Why don't we do that here first?
Yeah, so basically, generally, when you look at the effects of the BTK inhibitors, actually, we see very rapid responses. So the IgM levels go down. But if we have to stop the drug, for example, for a surgical procedure, or because the patient has an infection for which we have to sometimes stop it, you can see that the IgM level very quickly goes up again. So I'm not sure with the current BTK inhibitors you can stop the treatment without the IgM level and the disease.
I always feel like you're putting a lid
yeah.
on it.
Yeah.
When you take the lid off, then
yeah.
right back where you started. Like with chemo, it might stay away for a long time. But with BTK, you might have to quickly move to another treatment when you stop. Yeah. So you need a plan already. When you stop, you need to already have your backup plan.
Well, I think another interpretation of this question is, well, what if my current BTK inhibitor stops working?
Yeah, so it could be either because you have too many side effects, and then you could switch to another BTK inhibitor. But if it stops working, it could be because there is a mutation, so the BTK is no longer sensitive to the inhibitor, or there is a mutation downstream in the signaling pathway. Then you could go to the pirtobrutinib that was now mentioned, because it's a different type of BTK inhibitor. But it depends on what the cause is.
Any comments from the UK?
I just completely agree, but just to add, I guess, as already been said, it kind of depends what the treatment you go on to next, whether that also is a continuous therapy. So I guess in theory, as drugs develop and as we start to combine some of these targeted drugs, there may be a time where you go from a continuous BTK inhibitor to a drug that's only for a fixed duration. But at this moment in time, generally, patients are going from one continuous therapy. And when we say continuous, we mean you carry on taking the drug for as long as you're responding or not getting intolerable side effects, to another potential continuous drug. But things are changing.
Okay, and let me just test my understanding. My understanding is that, say my body is a WM cell, and here is where ibrutinib attaches my shoulder, and so does acalabrutinib, and so does zanubrutinib. So if one of them stops working, none of them are going to work. But pirtobrutinib attaches over here on my elbow, so that will work. Is that? These guys are nodding. I'll take that as a yes.
Yeah.
I think it's a nice metaphor, yeah. Yeah.
But I don't think the pirtobrutinib, we don't have any access to it. The company does not have a named patient program, so they do not give it away.
Yeah, actually they have it, but they cannot produce as much drug as is needed.
Yeah.
So they have stopped the named patient program to preserve patients already in to receive the drugs until progression.
Yeah. But they stopped it already.
We do know people in the U.S. that are on that trial and doing extremely well with it.
Mm-hmm.
So it does give us hope if the right shoulder drugs stop working. The next question is, this person wants to just say, great job putting this event on. I think we can all agree with that. And this question, I'll send it to the UK. What is the one thing you would tell a newly diagnosed patient to make sure they do in dealing with their diagnosis and treatment?
One bit of advice, is it, or one?
Tell a newly diagnosed patient to make sure they do in dealing with their diagnosis and treatment.
I suppose I would just ask the understanding and maybe just have a few repeated appointments initially, just to make sure questions are answered. So I suppose my one bit would be come back and see us very soon.
Anybody else there?
I think seek out information from the right sources so that you get accurate information. Dr. Google has a lot to offer, but a lot of it's either out of date or inappropriate. So I think go to specialist organizations like IWMF and WMUK, as well as your healthcare team.
And I was going to say to breathe and take a moment, because you don't have to become a world expert the week that you're diagnosed. This is a chronic disease. You've got time to learn about it. So take all the time you need. We all learn and understand things at different rates in different ways. So seek different sources of information and listen to the other things like Izzy was saying and Vern was saying about looking after yourself, because you're a patient and not just defined by the disease.
You also don't have to refer to yourself as patients. I guess is something you might just not want to associate with that as such, and that's okay. I'd just say to prioritise, what's important to you and have a real think about that.
MJ, you wanted to say something?
Yeah, so my first instinct is join a patient organization because not only can you find the right information, but also I think it gives great empowerment to actually actively join an organization. And,
Okay, I understand the UK is going to be with us for about another 8 minutes, and then you're dropping off. So we're going to keep going. Next question is, does WM always progress? We'll go to the UK.
I would say no, because we know that there are many patients, a good proportion of patients, that will never require therapy for their WM. Now, if we all lived forever, then maybe it would be a different story, and eventually it would. But no, there are many patients where they will not need active treatment for their WM.
Any comments here?
No, it's true. So the depends, of course, also if you have IgM, MGUS, or an asymptomatic Waldenstrom or symptomatic Waldenstrom. So the percentages are different, but there's certainly a high percentage of patients who are persons, I won't say patients, who will never need treatment at all. So that's also quite important.
Well, I like that personally. I was diagnosed in July of 2006, and I've never been treated. So I hope to definitely die with it, not from it. The next question is, where do I sign up for clinical trials? Let's start in the UK.
So there's different kinds of clinical trials. There is trials where, as most of us think about when we're thinking about trials, where you're testing new drugs or drugs that we know about but in new combinations or at different stages of your therapy. So there's lots of different trials. Your healthcare team should talk to you about if there is a trial available when you need treatment, even if they don't have all the trials open in their centre. They will talk to you about trials in other centres that might be appropriate for you. But there are other kinds of trials as well that are still really important for us to gain information about WM, such as the ones that WM UK are helping to run and other ones around the world. So, getting patient experience on drugs, understanding the disease better. So things that we call real world evidence, if you like, that we're just getting more information about the disease and its response to different treatments.
And I would add also that collecting the real-world data is going to help in every aspect of trials. We have a better idea of how many patients there are, what kind of disease they have, and what their quality of life is like. And we are certainly at our end of the meeting, we're going to soon hear about the role of wearable tech and how we can actually collect daily life experience of living with WM and how we can then leverage that to improve outcomes. And of course, I do support Monique's plea for biobanking. I think that's super important. And so I think the best thing is to ask your healthcare professional what is out there, and if go to the patient organizations, and also don't be afraid to have a second opinion from a specialist centre, because you can visit them even just once. They may actually then put you on a registry, for example, and then you can carry on sort of shared care.
Okay. The next question, I want to give a little background for the people in the UK. Yesterday we had a patient affiliate meeting here. So we have people here from 5 continents. We have people from North America, South America, Africa, throughout Europe, and China and India. For some reason, the Penguins from Antarctica didn't send anyone, and we also don't have anyone from Australia. So with that as background, do we know why more males and more white people, especially Ashkenazi Jews and non-Hispanic, and mostly white males over 65, get WM? We'll start with you guys in the UK. Did you get that question?
I think it depends where you look. I would argue that if the data comes out of the US or Scandinavia or places where there's really good data collection, the denominator there is predetermined. I think our own experience in the UK is that actually it's much more multi-ethnic than we think, and the demographic is not quite as it seems. So we do actually have an ethnicity abstract at ASH this year. I encourage people to look at that. I think it's more varied than we think. So I'm not going to venture into any explanations as to why certain trends exist.
And any comments here?
Well, I think in the Netherlands we have a very good registration, the Dutch Cancer Registry, and we do see the male predominance. We see that also in other types of cancer like myeloma or other types of lymphoma, and we actually do not know why exactly. And from the ethnic background, I'm also not so sure if that's
I think
right.
I showed a graph from a paper from Mary McMaster, who did a nationwide population-based study in the US. I think pretty big numbers. I think there are some differences, and it's probably related to the same thing as the familial clustering. There are genetic parts that are probably very complex that we don't completely understand. That might contribute to these differences. But yeah, indeed, we don't know is the answer.
Short answer. Yeah.
Okay.
Very short answer.
Let me ask one last question before you guys disappear. What is the role of diet and specifically sugar in the growth of cancer cells? UK.
What are you implying, Carl?
Beats me. I'm just reading the questions people wrote. Don't blame me.
I think it's very complex. I think we are what we eat, to be fair, but there's my own belief at least, is that there's the influence of the microbiome is probably, it's being looked at. That's the little guys who live in our guts and influence our health in big ways. So I think there's a lot going on in that space, and I'm really interested in that, to see how that impacts on the immune system and everything else. I think the sugar story is a little, in my mind, it's rather simplistic because I know some people feel if they take sugar, they're going to feed the cancer. But we do have a metabolism that takes care of that. So unless you're diabetic, I don't believe that, excluding sugar is going to reduce your cancer progression. I just don't think that makes sense, really. But if you're diabetic or pre-diabetic, then please take necessary precautions.
I think it goes, like you say, I don't think that we've got evidence at the moment that having a lot of sugar in your diet is going to change the outcome of the WM. But as has already been said several times before, that it is good to try and live a healthy life. And I always tell my patients it might not affect your WM, but it will affect you as a person, managing the side effects of the drugs, managing fatigue, for example. A good diet is going to help contribute to managing that. So I definitely would suggest a good, healthy diet, but not necessarily cutting out all sugar.
That sounds like a Dr. Google thing, right? Now, do you guys really have to go now?
Looks like yes, we're getting instructions.
Okay, I got instructions that you had to go. I want to make sure. We thank you for your participation. It was invaluable. Wonderful.
Thank you. Thank you all as well.
Thank you. We're going to continue on with our Ask a Doctor questions because we have a little more time. And now I won't get the B's and A's and C's and all that stuff messed up. But this has gone blank again. But I can make up questions. I want you to know the first time she had to take it over there to get it fixed, so it wasn't just me. Oh, we got different technology now. What are the signs that IgM MGUS is becoming WM? That's for you guys. What are the signs IgM MGUS is becoming WM?
Yeah, we should make a difference because before doing bone marrow biopsy, every IgM gammopathy might be MGUS, an IgM MGUS. Then if you perform bone marrow biopsy, the doctors can distinguish between MGUS and Waldenstrom. So the difference is another. So when you are totally asymptomatic and when you become symptomatic.
Yeah.
So this should be the difference.
I agree. It's a very artificial cutoff, the 10% infiltration in the bone marrow.
Yeah,
it matters more whether you have, because we increasingly realize that sometimes of MGUS can also cause specific symptoms. For example, anti-McNeuropathy.
Yeah.
Patients usually have MGUS type bone marrow, but they do have a lot of symptoms. And someone with asymptomatic Waldenstrom may live for 10 years without any problems. So I think that is the more. Yeah, you shouldn't be too afraid from which stage you're in. It's more important what symptoms you have and the burden of disease in one specific patient.
Yeah, when you start to have symptoms that sometimes can be difficult to diagnose, like for example the renal impairment. So also nephrologic symptoms might be related to Waldenstrom, or neurologic that can be difficult to be diagnosed.
Yeah, perhaps I can also add something while you're fixing that. It seems to be a bit of a. I think it's an important distinction that we make, but there's a new kid on the block, and we call it not MGUS, but monoclonal gammopathy of clinical significance, and so that's why it's always important when you have symptoms and you are in the MGUS stage to tell them to your doctor, because. For example, heart failure can be sometimes caused, if it's heart failure with a very thickening of your heart, it can be caused, for example, by amyloidosis. And that's something that can be caused by the M protein produced by the MGUS, small MGUS clone. But if it's producing a little bit of a toxic protein and you have that for several years, then you can have heart failure. So it's something that perhaps I would like to advise, tell all your symptoms to your doctor, so they can assess if it's something different or not, or send you to a cardiologist or neurologist if it's related or coexisting, and that's really important. And don't. Luckily, it's quite rare. So most patients just have ordinary AMCUS, but it's good to have that in mind that sometimes it can be related, and it also means that you need to be treated, because the M protein is so toxic. We have to lower it to normal levels, because it's elsewhere your disease is going on and on.
Okay, the next question is, you probably can't answer this. How long is a typical remission after chemo?
It depends on the kind of chemo and depends on when you started. Is it first line or second line or later line? But we see that with different regimens that are used most often is rituximab with bendamustine or rituximab with dexamethasone and cyclophosphamide, so the DRC. You can have remissions between a median of 3 and 6 years. That means that that's the median. So you have patients who have a shorter remission, but you also have persons who have a longer remission.
Right.
Yeah.
And I know it goes anywhere from 2 years to 15 years.
Exactly. Yeah.
Whatever. Next question is one of the long-term side effects of treatment or the actual disease painful joints like hands, wrists, knees?
Arthritis again, eh?
Yeah.
It's a big topic. I think Shirley answered the question about joint symptoms at the beginning of the session, and I talked to someone during one of the breaks, and I said the exact same thing as Shirley. So I think it's rare in Waldenström. It's not a very typical symptom that we see all the time, but we do see it, and I've had patients with real arthritis, swollen joints and everything, and when we treated the Waldenström, it was gone, and when the Waldenström came back, the joint symptoms also came back. But these are exceptions. I do think that, like Shirley said, the trick is that arthritis or joint symptoms can occur in people regardless of the Waldenström. So I always send people to a rheumatologist to rule out that it's rheumatoid arthritis or arthritis associated with joint surmenage. And so it's quite complex to distinguish whether this is then related to the Waldenströms or not. And in terms of treatment, in my experience, neuropathy is a bigger problem than joint pains with the treatments that we give. But I don't know what the others...
You do see it with the BTK inhibitors.
Yeah, with BTK inhibitors you can get muscle pain or joint pain.
Yeah. And strangely enough, also when you stop the BTK inhibitor, you can have like sort of a withdrawal syndrome where you also have these joint pains and inflammatory. Yeah.
But it sounds like it's a topic that we should pay more attention to, and it's coming back in your questions. Yeah.
Now here's a wide open question. Could you say a little more about cold agglutinin?
Everyone
Josephine
looks at the ice queen.
That was obviously from someone from Scandinavia, I bet.
Yeah, cold agglutinin disease is indeed something that Annemarie is also doing research on this. It's a really special subtype. I think what we're learning is that a lot of the people that have cold agglutinins, these cause destruction of the red blood cells, so it causes anemia in a different way than Waldenström does, and it causes a very specific symptom that only occurs in this disease, which is called acrocyanosis, and it means when your body cools down, and this is typically the tip of the nose or the fingertips, the blood cells agglutinate to the IgM, and it becomes blue or purple, it can tingle, it can even be painful or numb. And then when people go back in again into a warm room, they will warm up and this symptom goes away. It's a very special symptom. We don't see it in any other diagnosis. And cold agglutinin disease, you could consider it like a little cousin of Waldenström because it also has IgM, it also has bone marrow infiltration. But if you look more careful at it, it has different mutations. So it does usually not have MYD88. It has mutations that we see commonly in other types of lymphoma. So it's more like marginal zone lymphoma in a way. So it's like its own little entity, but it of course shares a lot of similarities with Waldenström, and the trial we're doing for this condition is with a BTK inhibitor. Of course, we borrow from the experience with Waldenström and other lymphomas. But it's one of those diseases where you often have MGUS type infiltration, and because of the IgM has these typical properties in the cold, you can get symptoms even at very low tumor burden. So it's
and you can measure it in the blood?
You can measure it, but it's hard to quantify. We're working on that actually as well to get a better, to get more precise testing for that. But you can definitely diagnose it in the blood. Yeah, for sure.
Okay. And this next question is for you, Dr. DeWinger. It's a bigger question, one we really all want to know. We've asked them specific questions, but this is what we really want to know. How do we live a normal life living with WM? You got 30 seconds.
You can do it.
Yeah, definition of normal life, please. But I think that the feeling that you have a normal life, if we just put ourselves back in the COVID situation, we at some point all found it normal to wear a mask, and at some point we found it not normal to wear a mask, and that changed all the time. And we humans, we are. We get used to stuff, and so I think it's more that you have to create a new level of normal and get used to that new level of normal, so that you feel like, yeah, okay, I can live with that. That's a new normal life. I think that's the thing I can say to that.
Do you have I don't know if this is correct. I always tell people to take a year for this. Like, it takes a long time when you get this diagnosis to sort of incorporate it into your system and indeed find a new normal. It takes at least a year, I think, or maybe even longer.
It's also individual, but it takes time, because first you're shocked and then you get adapted, and then you find out that sometimes it's not as bad as you thought, or sometimes it's different than you thought, and you have to get. I always say it's like when someone breaks into your living room while you were sleeping, and then you have to get used to feel safe again in your house. And of course, in the first time, you get really excited when it knocks. But when things get on, then you just get used to that new feeling of feeling safe again in your home at some point. But you got a shock, and so getting that safe space again, that takes some time.
It's a good metaphor.
Yeah. Okay, here's a Bill question. How many times a day should we do the butterfly?
All day long, of course.
I need to do it about 100 times a day. I think. Okay. Here's an interesting question. How many WMers have experienced spontaneous remission?
I've never seen
it. No.
Well, I've seen IgM MGUS, the IgM disappear, but
not WM.
No.
So none.
So it can fluctuate. I mean, the IgM levels can decrease, but completely disappear. It's very.
No.
Because we wanted to find that person and clone them and steal some.
Exactly.
Okay. And this is it difficult to find enough WMers for phase 3 studies?
Sorry, is it?
For
difficult.
Clinical trials.
Yeah, so we did have one trial. It's called the Aspen trial. It was a trial with, I think in every arm, if I say it correctly, 150 patients. So it was a trial with 300 patients, a big international trial led by a pharmaceutical company. So there are sometimes trials being done, but you also want to, the company has to have an interest to have a trial this big in so many countries to have, because you don't want a trial that runs for like 7 years. You want to recruit your patients in 1.5 year, ideally, so you can have your results also a bit sooner. So it can be done. We know it can be done, but I'm not aware of any large phase 3 trials running at the moment. I'm looking at my
randomized phase 2, so it's a little bit smaller.
Yeah. Maybe you can. It was a phase 2 trial, but you had the experience with the HOVON 124. How it was to accrue, I think.
Yeah. So I think in that trial we enrolled 64 patients in 2 or 3 years. So in
3 countries, right?
Netherlands, Belgium, and Greece. Yeah.
I think the working with, again, the patient federation here can be very useful. One, because they can, not every doctor in the community will be aware of which trial is going on, when and where, and which criteria are there. And when you connect with your patient federation, they will know what's going on. And also because there will people there that can share their story about participating in a clinical trial, and that can be, well, can be either reassuring or maybe you found out, no, this is not for me. But yeah, I think that's also because we have a hematon in the Netherlands, which is very active also for the Waldenström group, and that really helped, I think, yeah.
I'm going to actually end this now with, I'm going to do something that would make my parents very proud. I'm going to answer a question all by myself at the Ask a Doctor panel. The question is, I'm the only WM patient, feel free to correct me, I'm the only WM patient in my hospital. Is there a good WM website to check on my treatment? Yes, iwmf.com or WMK, WMUK. Did I get it right?
Yeah.
Yeah.
I want to thank you.
And I also want to stress, I don't want to, but if you're the only patient in that hospital, or yeah, perhaps if it's possible for you, perhaps get to a medical doctor with some more experience.
That's actually a very good point. On our website, we have a physician's directory. These are people, many of them are on it, where you can get second opinions, and you should always try, if your case is difficult, you should get a second opinion. And your community oncologist doesn't know much about our disease, and you don't want them to be learning with you. You want to have somebody who already knows. So I want to end now with this session and thank you to each of our doctors. You're giving up your Saturdays and your kindness and your answers are, you don't know how valuable it is to us. Thank you.